Clearing question or a short note or a short case for sure. I mean a hit case for sure, which definitely would be a vascular necrosis. It's a huge topic and difficult to cover periodically in half an hour. But I'll try to do my best and cover as a decade of life with a male to female predilection of 7:3, except in cases of SME. It is a recalcitrant disease characterized by the death of the osteocytes and bone marrow and is caused by the cessation of blood supply to the affected subchondral bone. It has also been described as a coronary disease of the hip by Schneider. Immediately after the ischemic insult, the osseous tissue initiates a repair process with osteoclastic resorption of the dead trabeculae and apposition of new bone. The joint undergoes a fatigue failure which results in collapse of subchondral bone, deformation, pain and limitation of movements. As you all know, the blood supply of the femoral head and neck comes from three main sources: the intraosseous cervical vessels, the artery of the ligament of teres, and the retinacular vessels, which in turn arise from the lateral and the medial circumflex arteries, which are in turn branches of the profunda femoris artery. Etiologically, the causative factors of avascular necrosis can be divided into two main groups, that is the primary or idiopathic, which means that we don't know the cause of avascular necrosis. Nowadays, in today's day, it is less common to diagnose a case as idiopathic because over the years, number of diseases have been associated with the causation of avascular necrosis. And the second group is secondary, which can be further subdivided into traumatic and non-traumatic. The traumatic avascular necrosis can be a result of a displaced intracapsular fracture of the neck femur, in which case a 15 to 20% of incidence of avascular necrosis has been noted. The other traumatic condition which causes avascular necrosis is a dislocation of the hip, which is lasted in that position for more than 12 hours, leads to almost 25% of incidence of avascular necrosis. In non-traumatic variety, a number of illnesses have been implicated to be causing avascular necrosis, but the important ones being steroid intake, alcoholism or smoking, sickle cell anemia, thalassemia, Gaucher's disease, or Cason's or the decompression disease. 10 to 30% cases of avascular necrosis are attributed to steroid intake for various cases. Evidence is only circumstantial and the exact dose required to cause the avascular necrosis is not known. The mean daily or the peak dose rather than the cumulative dose or the duration appear to be associated with osteonecrosis, and a dose of more than 20 mg per day increases the risk significantly. Alcoholism is another important causative factor for avascular necrosis. Consumption of more than 400 milliliters of absolute alcohol per week has been thought to relatively increase the risk of AVN by almost 10-fold. Fat embolism and increased intraosseous tension due to hypertrophy of the lipocytes is thought to be behind the pathophysiology. Looking at the pathogenesis and pathophysiology, trauma causes a direct interruption or mechanical interruption of the blood supply of the head and neck. Alcohol and steroids lead to fat embolism and increase in the intraosseous tension. And the various coagulopathies lead to intravascular thrombosis with occlusion of the blood vessels. All of these eventually lead to a decreased blood flow to the head and neck of the femur, causing ischemia, osteonecrosis, which in turn leads to an onset of a repair process, the loss of structural integrity, a collapse of the necrosed or the dead bone, and eventually leading to secondary osteoarthritis of the hip. An early diagnosis of the avascular necrosis allows early treatment with a probability of a better outcome. A high index of suspicion is required, especially in cases of non-traumatic origin, and hence history taking is very important and associated risk factors should be sought out. In clinical presentation, deep pain in the groin is the most common presenting symptom, which may be progressive in nature and eventually may lead to limitation of activity. On examination, findings can be unremarkable or can include pain on rotations and tenderness on the hip anteriorly or a trochanteric thumb test possible. Decreased range of motion with differential rotations and antalgic gait or a clicking in the hip may be present. Shortening and severe stiffness are seen in the late arthritic stage. Coming to investigations, X-rays are the first investigations to be performed as in any other orthopedic case. Anteroposterior and frog-leg lateral are the standard views that we take in the beginning. They may be normal in the early stages, and as the disease progresses, crescent sign, collapse and late-stage arthritis are seen with advancing disease. Bone scan or technetium 99 bone scan are used less and less these days due to a 25 to 45% of false negative results. MRI today is now the gold standard with 99% sensitivity and specificity. It better delineates the lesion, and T1 images show a hypointensity signal. Double line sign, which was introduced by Michel et al., is seen in the T2 weighted images, is supposed to be diagnostic of the avascular necrosis. As you see in these images that are shown, this is the hypointense patch which is seen in the head and the neck of the femur. And this is the normal femur which is seen in the T1 weighted image. So this is the image which shows that the left hip is affected with the vascular necrosis. CT scan these days is rarely used due to the high cost and radiation risk, but can be of use in diagnosis of early collapse. Transient osteoporosis is the only condition that we need to distinguish from the early cases of avascular necrosis. Transient osteoporosis is a self-limiting disease with similar clinical picture in the early stages of the disease, but the MRI differs distinctly. In MRI of a transient osteoporosis shows a severe marrow edema in the entire upper end of femur and the head and neck. There is no specific treatment for transient osteoporosis, and usually it resolves on its own within a period of 6 months to 1 year. Classification. Investigators working on avascular necrosis have acknowledged that the uniform use of a single effective method for staging and evaluation provide many advantages. The system must be objective, relatively simple to use, and reproducible. It should avoid older and invasive methods like initially biopsy used to be done to reach or arrive at a diagnosis of histopathology. So as far as possible, the staging system should avoid such invasive methods and should include newer methods like MRI or magnetic resonance. A number of systems have been described, but the more popular ones are the Fickett and Arlett staging system, which even today is the most commonly used staging system for classifying the various stages of avascular necrosis. The second is the University of Pennsylvania system, Japanese Investigative Committee for Avascular Necrosis, and ARPO's system. These are the 4 systems which are commonly described and used. Fickett and Arlett staging system was first described in the 1960s and initially consisted of only 3 stages. In the 1970s, 4th stage was added, and a stage 0 and a transitional stage was added later. This is the most widely used system today, although with a major drawback of not being able to gauge the size of the lesion or the articular surface involvement. The following table shows the classification of osteonecrosis femoral head as seen in the Fickett and Arlett classification system, wherein as you can see it is classified into stage 0, 1, 2, 2 is further sub-classified into 2A and 2B, 3 and 4. University of Pennsylvania system, developed in the early 80s, defined 7 radiographic stages and included bone scan and MRI findings, and also a method to actually size the lesion and the articular surface involvement. ARPO appointed a committee which in the 1990s proposed a classification system combining both the systems of University of Pennsylvania and the Japanese system. It actually made the system more complicated and difficult to use, and hence that is why we use more commonly used the Fickett and Allen system for classification. Now coming to management. The management of avascular necrosis to date remains a perplexing problem. Without specific treatment, 80% of the cases would progress and will require eventually arthroplasty. The goal hence is to diagnose and treat the disease in its earliest stages. A number of surgical procedures have been described to retard or prevent the progress and to preserve the head, but none is entirely satisfactory. The various treatment options that are available to us can be grouped into two main groups, that is non-operative and operative. The non-operative group consists of physiotherapy to preserve the motion. Partial weight bearing can be tried only in the early cases with limited success. Pharmacological drugs like bisphosphonates and aspirin have been tried with limited success. Hyperbaric oxygen therapy has also been tried in early AVN, but again with limited success. A meta-analysis studies with conservative treatment has shown that success rate, which means that no further surgical intervention is required, of 61%, 59% and 25% for stages 1, 2 and 3 respectively of the avascular necrosis. Now let's come to operative choices of treatment. Operative management can be grouped into three further sub-classifications, that is head preserving, resurfacing and replacement. Head preserving can be core decompression, osteotomies and head decompression with bone grafting. Core decompression is the most common procedure used to treat the early stages of AVN. There is no general consensus regarding either the indications or the techniques that optimize the results. Originally, Arlett and Fickett had the area which is affected with a guide wire, and over the guide wire you pass a cannulated drill and actually drill that area. This helps to decompress the area and improves neovascularization, chances of neovascularization, and it is an attempt at healing for femoral head resurfacing and better if performed prior to the development of substantial degeneration of the acetabular cartilage. Potential candidates for limited resurfacing of the femoral head are the ones who are young patients with no or minimal degeneration of the acetabular cartilage, presenting with either a crescent sign or collapse of the femoral head, and young patients without femoral head collapse but with an extensive osteonecrotic involvement of the femoral head, wherein there is more than 50% of the femoral head involvement. Last but not least is the total hip arthroplasty. The advantages are that it gives excellent early pain relief and a good functional outcome. But the disadvantages are that sacrifices more host bone and hence narrows the future operative options. That is, when you are doing a total hip arthroplasty in younger patients, and if you need to revise it, say after 10 or 15 or 20 years, then the options become limited because it damages a lot of host bone when you are doing it primarily. Indications for total hip arthroplasty in AVN are osteonecrosis of the femoral head with associated advanced secondary degenerative arthritis with severe damage of the femoral head articular cartilage and combined with the loss of acetabular cartilage, and in older or low demand patients with extensive involvement or collapse of the femoral head as well as sufficient symptoms to justify total hip arthroplasty. Contraindications of total hip arthroplasty are young patients with early stage osteonecrosis of the femoral head for whom treatment options that can save the femoral head are still available, and patients at excessively high risk for complications of total hip arthroplasty. This actually can become a relative contraindication and not an absolute contraindication. To summarize, the primary goals of treatment of avascular necrosis are relieve pain, to maintain a congruent hip joint as long as possible, and to delay the need for a total hip arthroplasty. And when you are dealing with young patients, a more conservative surgical procedure should always be thought and planned for. Factors influencing the choice of treatment in avascular necrosis are presence or absence of collapse in the head, size and the location of the lesion, the amount of depression that is present at the first time of visit, and presence or absence of acetabular involvement. These are the main factors which would actually decide what line of management or what surgical procedure that you are going to use for the patient. This is a potential treatment algorithm that has been given. To conclude, avascular necrosis till date remains a difficult condition to treat, and that is mainly because of lack of understanding of the etiology of the disease, which makes it more difficult. There are a multitude of treatment modalities which are available, and I feel availability of growth factors may in future revolutionize the treatment of this condition.